Ladies and gentlemen, I am going to speak to an audience of diabetologists about something which concerns more with the prevention of heart disease. We are all into it in the same business of these preventing diseases, and blood pressure is one factor which is increasingly becoming a factor to be reckoned with in day-to-day practice. We all check blood pressure routinely in our clinic, and we also initiate treatment depending on the level that we find in a blood pressure clinic. It might be one or two readings before we initiate treatment, and we have called the patient for a follow-up, and we possibly even moderate the treatment, increase the treatment, or decrease the treatment. What I would like to highlight is that this method of controlling blood pressure may not be the ideal one. Let me make a comparison. If you are going to base your diabetes control only on random blood sugar being noticed in the clinic, would it be right? It won't be. You all will agree. There are multiple parameters to be checked. One of them is a long-term average of glycosylated hemoglobin, which gives a good idea of the control of blood pressure in the past 3 months. Similarly, the ambulatory blood pressure monitoring has come in a big force to identify factors which can prognosticate events, which can change the course of events in cardiac diseases. So what glycosylated hemoglobin is to diabetes control, I would say ambulatory blood pressure monitoring is to blood pressure control. We all know that control of hypertension is a very important factor that impacts the outcome of many diseases like coronary disease, heart failure, stroke, end-stage renal disease, and diabetes. Accurate BP measurement is essential for the diagnosis, treatment, and monitoring of hypertension. When we look at blood pressure measurement, that itself comes into a bit of a question, a bit of a cloud. Multiple factors can affect the blood pressure control. It could be the setting, it could be in the office, it could be the workplace, it could be ambulatory, or it could be at home. The time could be nighttime, daytime, when the person is working, sleeping, everything. And the blood pressure is recorded by many people, could be a doctor, nurse, technician, anybody. And the device used are also multiple. Could be mercury, aneroid, hybrid, oscillometric. Posture could be multiple. Reading could be multiple. It could be the first reading of the day, first reading in the clinic, or multiple readings in the clinic. And which blood pressure reading do we take to be the accurate for controlling the blood pressure and for initiating therapy or moderating therapy? When we look at the office or clinic blood pressure, there's a lot of difference between checking the blood pressure at home, out of office, and the blood pressure monitoring within the clinic. If it is outside the office, there could be multiple readings, could be multiple readings initiated by the patient, relative, or anybody. Or if you use an ambulatory blood pressure monitoring, there are sequential blood pressure monitoring recorded on a regular time interval, which is available for analysis. Ambulatory blood pressure monitoring was not a very useful tool in the past, but it has now come in vogue. There are certain limitations which can easily be overcome in using ambulatory blood pressure monitoring as a tool for controlling hypertension. It has been supported by multiple guidelines, American Heart Association, European Society of Cardiology, and National Institute of Health and Care Excellence. All of them have supported ambulatory blood pressure monitoring should be the benchmark for controlling blood pressure on a long-term basis. Why ambulatory blood pressure monitoring? Why do you require that when a simple tool like just checking the blood pressure in the clinic is sufficient or somebody checking the blood pressure at home is sufficient? You'll be surprised to know that many statistics have shown very varying results. 50% of controlled hypertensive patients which have been noticed in the clinic have uncontrolled morning hypertension. 67% of chronic kidney disease patients have a non-dipping pattern. I'll come to that later. 20 to 30% of hypertensive patients have resistant hypertension, which you would not diagnose if you don't do an ambulatory monitoring. 32% hypertensive subjects have white coat hypertension, for whom you might be needlessly starting hypertensive medication. 60% of sleep apnea patients are hypertensive, which again goes unnoticed when you check only the clinical blood pressure in the clinic. 13% of people have masked hypertension. So when we have a gamut of patients with varied levels of blood pressure going undiagnosed, overdiagnosed or underdiagnosed, we require a tool which covers all of them, and ABPM fits the bill perfectly. What are the clinical indications for an ambulatory blood pressure monitoring? You have to exclude white coat hypertension, elderly patients. I would also include in this a very young patient coming to you with hypertension. You have to do an ambulatory blood pressure monitoring. It could be just an sympathetic overdrive. Identification of nocturnal hypertension, deciding diagnosis in borderline hypertension, paroxysmal hypertension, hypertensive patients resistant to treatment, and to diagnose hypertension and prognosis of hypertension treatment, also you require ambulatory blood pressure monitoring. Previously, the equipment available for ambulatory blood pressure monitoring was a bit cumbersome, a bit bulky. Now the equipment that is available is quite sleek. It is like the kind of iPods or iPad that we use for while jogging. We can connect it to the patient and the recording of blood pressure goes on. And the cuff is tied and the tubings go unobtrusively under the skin, under the dress of the patient, and he can go back to work with the blood pressure monitoring tied to him. What are the techniques of ABPM? Most monitors use the oscillometric technique, which assesses oscillations caused by arterial pulse pressure. These oscillations are produced when the ABPM cuff occludes the patient's artery, something similar to the Korsakoff sounds, but in an oscillometric recording. The data produced by ABPM session is stored in the monitor and later downloaded for analysis by device-specific software, which we have in our clinic. Currently available ABPM devices have been independently validated, most often following the European Society of Hypertension International Protocol. In ABPM, what all information do you get? You get the mean blood pressure level, the diurnal rhythm of blood pressure, mean daytime and nighttime blood pressure levels, blood pressure variability, heart rate and heart rate variability. You all know that all of them are important in finding out whether the person is liable to develop coronary artery disease in the future. The normal course of events, when the person goes to sleep, there is a dip in the blood pressure, which is between 10 and 20% from the daytime values. And the importance of this nocturnal dip has been recorded, has been analyzed, and we have found out a relation between excess dipping, no dipping, or low dipping related to diseases. And if you use the other methods, when you use in comparison, you will not be able to come to a true or mean blood pressure with the conventional method of recording blood pressure. Dipping status cannot be found out. Morning surge cannot be found out. Blood pressure variability is difficult to assess. And duration of drug effects also is difficult to assess with other methods of investigation. Whereas if you put the person on ABPM, the results are excellent. Office-based BP readings are limited in the amount of information they provide, as they represent a single snapshot in time. Limitations are low reproducibility. Various staff members may obtain the BP at each visit, or you yourself might be rushed for time, possibly not taking adequate reading, cannot detect white coat effect, masked hypertension, nocturnal hypertension, and early morning surge. What are the normals of ambulatory blood pressure monitoring? Office BP, if it is more than 140, we all know that by the current JNC recommendation, if it is more than 140 and more than 90, we call it abnormal. By ambulatory blood pressure monitoring, daytime reading more than 135 and more than 85. Nighttime ABP more than 120, more than 70. That means we factor in the dip that is expected. 24 hours ambulatory blood pressure reading more than 130 on average and more than 80 on average is abnormal. And home BP, which the person records by himself, more than 135/85 is abnormal. Ultimately, we do these studies to find the prognostic significance of all these readings that we get by this ABPM. Left ventricular hypertrophy, carotid intima medial thickness, and other markers of occluded diseases correlate more closely with ambulatory blood pressure monitoring than with the blood pressure monitoring recorded in the clinic or at home. 24-hour average blood pressure has been consistently shown to have a stronger relationship with morbid or fatal events than office BP. So your reading of blood pressure in the clinic may not give a snapshot into the future of the patient, whereas ABPM is definitely going to give you an idea as to what direction the patient is headed for. Evidence for meta-analysis shows that ambulatory BP in general is more sensitive risk predictor of clinical cardiovascular outcomes such as coronary, morbid or fatal events and stroke than the office BP. And they have correlated the ambulatory blood pressure monitoring in elderly patients and correlated with the reading that we found. And when we found that the ambulatory blood pressure monitoring consistently reduces and with treatment the pressure has been brought down consistently with an ABPM analysis, we find that the benefits are significant. Hypertension could be classified in various ways. It is not just one benchmark. It could be white coat hypertension, where the patient has blood pressure only in the clinic in the presence of doctor or paramedical personnel, whereas outside the office, these pressures are normal. Could be sustained hypertension, where the BP is more than 140/90 in the office and 135/85 in the ABPM. True normotension is below 130/80 by ABPM and 145/90 in office. And here again, one more factor, 120/80 during sleep. And MASH hypertension, where in the office it is less than 140/90, but out of office is more than 140/90. This is opposite of white coat hypertension. You find that there is a varied distribution of patients with hypertension. 8% had MASH hypertension, that means in the clinic it was normal, outside the clinic it was abnormal. Sustained hypertension has been documented by clinical recording as well as by ABPM recording. Normotensive in 68% and white coat hypertension in 9%. So nearly for 32% of the patients, we are missing the diagnosis without the tool of ambulatory blood pressure monitoring. Don't you think it is a big number? I think we have to target that group which is going to be useful. In white coat hypertension, we are giving unnecessary medication, whereas in other two groups, we are not providing adequate medication. And when you find that the blood pressure is more, you'll find that there is always a group which has got increased incidence of cardiovascular events. Sustained hypertension, MASH hypertension, white coat hypertension, and normotension. When you look at all these factors, you find that when blood pressure is controlled by all parameters, the incidence is quite low. Even when otherwise daytime is more than 130/80. So we have to take efforts to control the hypertension not only during the small snapshot of clinical examination in the office, but also his activity during the daytime. And you only find that when there is a sustained hypertension, there is increased incidence of cardiovascular disease. MASH hypertension also is there, whereas white coat hypertension, the incidence is much less. So, if you are able to categorize the patient and treat him according to what his real needs are, possibly we will be more successful in preventing cardiovascular diseases. And here again, cardiovascular disease and all-cause death in the Pamela study, you will find that the white coat hypertension is not entirely a benign condition. But mass hypertension and white coat hypertension also have a certain role in producing disease. You should remember that possibly the white coat hypertension is a precursor of sustained hypertension later in life, and this patient needs to be kept under observation over a long period of time. There are no data to say that white coat hypertension will transform into a sustained hypertension, but this is only a conjecture. Another factor which we can easily identify with ABPM is morning BP surge, which cannot be found out by other methods of investigation. Nobody is going to bother checking the blood pressure the moment he gets up in the morning. Normally, there is an increase in the blood pressure in the morning. As soon as the person wakes up, is a wake-up mechanism, there is an increase in pressure. And this you all know that is responsible for increased incidence of cardiovascular and cerebrovascular morbidities and mortalities produced by early morning surge. There is a sudden increase in blood pressure which leads to changes in the inflammatory status, produces plaque instability, and produces plaque rupture, thrombosis, and cardiovascular and cerebrovascular events. These could be prevented by reducing the early morning surge, which can be identified only by ABPM. Morning BP surge increases cardiac afterload and arterial stiffness, contributing to the progression of left ventricular hypertrophy. In hypertensive patients, the surge has been significantly correlated with the LV mass index. And you all know the LV mass index is one of the risk factors for cardiac failure. Sleep-through surge was significantly associated with the increase in carotid intima media thickness. Carotid intima, CIMT, is a surrogate of coronary disease marker which can be easily measured, and ABPM has uncovered it. The newly diagnosed type 2 diabetic normotensives, morning BP levels and surge were significantly higher in patients with microalbuminuria than in patients without microalbuminuria. So a person with microalbuminuria, you might find that there is an associated increase in the early morning surge, and that could be a pathological feature. Nighttime blood pressure is very important in analyzing patients. Normally, there is a 10 to 20% difference between day and night levels of blood pressure. A nighttime fall in BP is normal and desirable. The classification of non-dippers, where the decrease in pressure is less than 10% is called non-dippers. Dippers are 10 to 20%, which is normal. Extreme dippers are more than 20%, and reverse dippers are those with higher blood pressure at night compared to daytime BP. What are the implications? If you find that the blood pressure falls by 10 to 20% from the daytime BP, it is a normal response. If the blood pressure falls more than 20% or falls less than 10%, it is abnormal. This is a non-dipper where there is a less than 10% drop from the mean blood pressure during the course of the day, and that is pathological. And if the blood pressure falls more than 20% during sleep, that also is pathological. There is something to be seen. And there is something called reverse dipper, where the blood pressure, instead of dipping at night, it goes up at night during sleep. This again is pathological. Nighttime BP is a stronger predictor than daytime BP. How do you check it? Only by one method, ambulatory blood pressure monitoring. The day to night ratio predictor of clinical CV outcomes. Lesser drop in night BP, there is higher incidence of CV events. Extreme dipping is increased risk of stroke. Also a risk factor for LVH, silent cerebrovascular disease, microalbuminuria, and progression of renal damage. ABPM is the only practical method to determine dipping pattern. Labile hypertension, ABPM may prove helpful in some patients with a history of paroxysmal hypertension. Pheochromocytoma has been mentioned, but normally we don't get this kind of a labile hypertension always in pheochromocytoma. A much more common cause of labile hypertension is panic attacks, which have been shown to be accompanied with surges in both BP and heart rate. Antihypertensive treatment based on conventional or ABPM, 419 patients were assessed at baseline and antihypertensive therapy was adjusted in a stepwise fashion on the basis of measurements at 1, 2, 4, and 6 months. Fewer progress subject to multi-drug therapy as compared with conventional measurement. Adjustment of treatment based on ABPM instead of conventional blood pressure monitoring led to less intensive drug treatment, preservation of BP control, general well-being, inhibition of LV enlargement. It means that we are using the appropriate dosage, appropriate combination, and appropriate level of blood pressure has been controlled with the use of ambulatory blood pressure monitoring. ABPM helps evaluate whether additional therapy is needed. In 611 patients with elevated office pressure, 28% of resistant hypertensives had normal awake BP. Approximately 1/4 of patients with apparent resistant hypertension had controlled blood pressure. ABPM is an appropriate clinical step before ordering further workup in these patients. One half of older controlled antihypertensive patients studied at home were actually controlled according to ABPM regardless of treatment status. This suggests reconsideration of treatment needs in these numerous white coat hypertensive patients who probably do not need drug treatment initiation or intensification. This only means that we are optimizing the blood pressure treatment by objective data. If you look at the daytime and BP control in hypertensive patients, you find that if it's untreated hypertension, almost 56% are not controlled. Undertreated patients, 65%, and treatment-resistant hypertension is found in 55% patients, and both nighttime and daytime control are out of order. BP control was poorer in the night period than in the diurnal period, especially in the apparent treatment-resistant hypertension group. ABPM, there is a practical algorithm. We monitor the patient. Self-monitoring or home monitoring is allowed, or you perform ambulatory monitoring. If the BP is consistently below 130/80, non-drug therapy. If it is more than 130/80, initiate antihypertensive therapy. Again, perform an ambulatory BP monitoring. And once the target BP is reached, then you maintain the present therapy. If the target BP is not reached, you change the antibiotic therapy. ABPM in routine clinical practice. Although evidence supports the role of ABPM in the diagnosis and management of hypertension, the technology remains underused. These barriers primarily include lack of experience interpreting the results of ABPM, lack of familiarity with the technology, and economic issues. Recommendation for ABPM in clinical practice. JNC 7 says you should use a white coat hypertension, labile hypertension, resistant hypertension, hypotensive episodes, and postural hypotensions. If all these have been suspected, you order a ABPM. ESH-ESC hypertension guidelines of 2013. The major advantage of out-of-office BP monitoring is that it provides a large number of measurements outside the medical environment. In addition, out-of-office BP measurements are most closely monitored to end organ damage and cardiovascular events than the office BP measurements. Well, office BP is still the gold standard for the diagnosis of hypertension. I would say you would hit the bullseye with ABPM, and you might have a scatter shots with home blood pressure monitoring or with clinic blood pressure monitoring. Thank you so much.